Evening, everybody, and happy to see all our committee members and all our participants here for our final workshop, I guess, to do with this year's overall events. So my topic for the day today is glucose monitoring in pregnancy. Like we all know, glucose monitoring is the cornerstone of management of diabetes in pregnancy. And pregnancy, like we know, is a very short period. And if we establish short-term intensive control of diabetes for our diabetic women during this period, the payoff that we get is indeed very long-term in terms of the prevention of impaired glucose tolerance, obesity, diabetes in the offspring. So as a result of which we need to leave no stone unturned. We have to come out with all our guns blazing where it comes to establishing tight diabetes control, glycemic control for our women with diabetes in pregnancy. So going from there, one second, I'm just going to minimize this. All right. The definition, I'm just going to give you a very brief definition of GDM. GDM now basically is defined as diabetes diagnosed in the second or third trimester of pregnancy that was not clearly overt prior to gestation. Now, this definition is now adopted by the IDF. The reason this definition is given is primarily to differentiate GDM from type 1 and type 2 diabetes. In the past, the definition that was used, and in fact, what is used even by the Indian Ministry of Health and Family Welfare, is still first recognition of any glucose intolerance in pregnancy. But this, by the way, is what IDF and majority of the societies have adopted. Now, like we know, with obesity, PCOS on the rise, GDM also has been steadily increasing, to the point now that in 2019, the IDF estimate was that 1 in every 6 of the 20 million annual live births occurred to women with some form of hyperglycemia. 16% are with diabetes in pregnancy, 84% are those with GDM. So the question is, why does GDM develop? Now, like we all know, pregnancy is the greatest glucose challenge test. And the reason for that is because in pregnancy, one of the big metabolic responsibilities of the mother is to make copious amounts of glucose to supply the growing fetoplacental unit. How does that happen? In early pregnancy, this is via the anti-insulin hormones, and in the later part of pregnancy, the maternal liver is putting out a huge amount of glucose to provide for the fetal growth. Now, one would imagine that with such huge amounts of glucose being pumped into the maternal circulation, the mother's glucoses would go high. But if you look at the normal maternal glucoses in normal pregnancy, the mean fasting plasma glucose is roughly around a 74 mg per dl. The PP peak is roughly only a 108 mg per dl. So how does this happen? This is because when the maternal glucose goes high due to so much excess production, this is compensated by the development of a physiological insulin resistance, which causes a compensatory hyperinsulinemia, due to which the normal metabolic adaptation is to bring glucoses into this level. However, if a pregnant woman is not able to increase her secretion, insulin secretion, to overcome this insulin resistance, to match the increased glucose production, that is when this topples into hyperglycemia in a normal pregnancy. Now, like we just heard a little earlier from Dr. Sujata, this basically maternal hyperglycemia will then translate into fetal hyperglycemia. The fetal hyperglycemia triggers the baby's beta cells in the baby's pancreas to start producing more and more insulin, which then translate into fetal macrosomia. Simultaneously, because of this hyperglycemic environment in the fetus, there is basically an intrauterine programming of the beta cells to cause a subsequent expression of obesity and type 2 diabetes in this baby's future life. So, as a result of which, why do we have to care about tight glycemic control? And as the previous speaker gave us a whole background on all of this, there is an increased, a twice increased risk basically of macrosomia, of fetal adiposity, and a much higher 50% excess risk of preterm delivery shoulder dystocia. Alongside with this, you have the long-term cardiometabolic complications in the mother and child. And as it was shown in the HAPO and the HAPO follow-up study as well, even those with mild glucose intolerance, when their glucoses are tightly controlled, all of these complications can well be prevented. So like I always like to do, I'm going to put in a small little case to discuss because my topic for today is glucose monitoring. So let's see about the different ways that we have to monitor glucose and where we should use each of them in what kind of scenario. So over here we have Sita. She's a 22-year-old primie, who's come to your clinic for her first ANC visit at a 16 weeks of gestation. Her BMI is 20. She has no significant past medical or family history, and her preconception A1C that you had tested prior to pregnancy was a good 5.5%. So the question over here is, would you screen for GDM now? Now, one thing I'd like to point out is the reason that I have put her BMI over here is because the pre-pregnancy BMI alongside with the duration and extent of maternal hyperglycemia are actually some of the best predictors for progression of diabetes in the patient's postpartum follow-up. So therefore, this BMI is an important predictor as well. And this preconception 5.5, like we know, we have to optimize preconception care. So an A1C of less than 6%, and some societies, like we'll see later, of 6.5% is where we need to get our patient prior to pregnancy planning as well. So the question is, would we screen right now? And I hope that everybody in this group has basically in their minds thought of a resounding yes. Now, the reason for that is that in our scenario, we have a 10 to 11 times greater risk of developing diabetes as we are a very high risk ethnic group. Asian people have an 18.9% greater risk of developing GDM compared to the risk. And it's probable that because we are not routinely screening all our women for GDM, it's probably this undiagnosed glucose tolerance that has been occurring in the past that has resulted in the increased prevalence of diabetes in India. Well, that's really something to think about. Like I said earlier, preconception, we have to optimize the environment. Different societies give different goals. The ADA goal currently is less than a 6.5%. However, this, depending on whether we are able to achieve it without hypoglycemia, is of course has to be considered, and individualized targets sometimes need to be met. One important factor about the A1C also is that a normal A1C in pregnancy is usually lesser. And that is because, so that I'm talking about in pregnancy, and that is because the RBC survival time, the RBC turnover is much, much faster, just about 90 days, therefore corresponding to a lower A1C during pregnancy itself. Now remember that in preconception care for women with established type 1 or type 2 diabetes, if a woman is of childbearing age, does not want pregnancy, effective contraception should be advised, and the patient evaluated for diabetes-related complications, such as your heart disease, kidney disease, retinopathy, etc. But a woman with established type 1, type 2 disease, wanting to become pregnant, we have to, at that point of time, review her risks of uncontrolled diabetes in the pregnancy. And of course, at that point of time, counsel her on medication use, particularly those that are contraindicated during pregnancy, like statins, ACE inhibitors, ARBs, and a lot of OHAs as well. For some patients who are already on OHAs, you might want to, talk to them about the point at which you want to make the switch from OHAs over to insulin, whether pre-pregnancy or during pregnancy itself, if needed. Now, Sita over here at her first ANC visit, 16 weeks of gestation, we said, she's come to you and now we've decided that we want to screen her. So the question is, how would you monitor, how would you screen her glucose levels at this point? Would you do a fasting NPP glucose? Would you think of an HbA1c, a 50-gram 1-hour, a 75-gram 2-hour, or a 100-gram 3-hour OGTT? And the truth of the matter is that there is a huge amount of discrepancy, debate, controversy amongst the various societies about what is the ideal way. So I'm going to show you over here what the ADA in 2018 have been following as their two-step strategy. Basically, over here, a 50-gram non-fasting glucose challenge is given. If this is more or equal than 140, then the woman has to, in that kind of case, do a 100-gram OGTT fasting. And if 2 out of these 4 cutoffs are crossed, this makes for a diagnosis of GDM. And If and the ADA also endorses the IADPSG criteria, which basically involves a simpler one-step universal strategy, which is basically at 24 to 28 weeks, a 75-gram OGTT is done. And if any one threshold value is crossed, any one out of these three, again, this makes for the diagnosis of GDM. And this is basically the criteria that is used worldwide at this point of time for the diagnosis of GDM. In India, basically, we are, like we said earlier, a high-risk ethnic population. And for us, universal screening is the order of the day. So what we need basically is a simple test. And what we follow right now is the 75-gram glucose challenge test. It involves a single post-glucose PG value at 2 hours. This basically can be done even in a non-fasting state, preferably at the first visit when the patient walks in, and in small towns and villages where a venous glucose sample cannot be collected, even as a finger prick glucose level is acceptable. If this is more than or equal to 140, it makes for the diagnosis of GDM. If this is more than or equal to 120, this is what we describe as decreased gestational glucose tolerance. Remember that if it is in that 150 range, don't lose that patient off your radar, because the chances of her developing diabetes as she enters into later parts of pregnancy are extremely high. And in fact, if in the first trimester, if the patient is negative, the testing is repeated at 24 to 28 weeks. And if you're still kind of, uncomfortable, a little suspicious, you might want to do it in the third trimester again as well. So this procedure basically from the Indian public health setting is simple, feasible, and economical. So just to reiterate here, Sita, we've done a 75-gram glucose challenge test. Her 2-hour glucose value is 140. This makes basically for a diagnosis of GDM. And that is something we need to, of course, imprint in our minds. So let's then move on to management. In diabetes in pregnancy, early referral to a specialist is essential, because this is a collaborative effort between the OB, the endo, the ophthalmologist, because progressive retinopathy is a well-known entity in patients with diabetes in pregnancy. A registered dietitian is a good idea to have on board always, and an educator as well, because the patient always needs to be educated to remain engaged in her care. The management, the checking, the taking of medications, staying good with the diet and all of that are not very easy in pregnancy. For all that we might sit and advise our patients to keep monitoring themselves, etc. Well, following this is not really everyone's cup of tea. So having an educator, if you have access to that, is a great idea. Very often we doctors have to remain the educators that constantly are empowering, encouraging, educating our patients to stay good with their care as well. Now, individualized plans basically will involve glucose monitoring, of course, which we're going to talk about a little further as well. Now, as soon as when we've made a diagnosis of diabetes in pregnancy, basically medical nutrition therapy is what we always start off with. If with 2 weeks of MNT, glucose targets are not met, that's when we move on to pharmacotherapy, which will of course be discussed later as this webinar goes on. Exercise, weight management, of course, have to always remain and have to be, we've already discussed that. Psychological support is very important. In fact, always having the spouse also come for the patient visits is important as well, because it's very important for the family members to understand the importance of this continuing care of diabetes in pregnancy as well, in order to keep the patient motivated. So what are our targets? As far as the A1C goes, during pregnancy, we want to establish a target. By majority of societies will suggest a target of less than 6. What about our fasting targets? Again, like you're seeing, majority of societies will recommend a fasting sugar of less than or equal to 95. IDF wants it as a less than 90. A 1 hour PP we want as less than or equal to 140, and a 2 hour at less than or equal to 120. Remember, of course, that it is the postpartum glucose, it is the PP glucose, not postpartum. It's the postprandial glucose that has been best correlated with macrosomia, and therefore keeping these values under control is important. So what are the infant outcomes? Is there any data about how tight glucose controls will impact this? Well, even early on, it's been seen that any serious perinatal complication, death, shoulder dystocia, bone fracture, nerve palsy, is much, much better when there is tight control as compared to routine level of care. Now, for pregnant women with diabetes, the methods that we have for monitoring glucose, the first one, like we all know and are all using, is self-monitoring of blood glucose. This is with your routine glucometer. We ask our patients generally to do a fasting, a postprandial, breakfast, lunch, dinner. For patients who have pre-existing DM, who are on insulin, etc., getting pre-meal sugars also will give us a better level of care. So very often this would involve, roughly, if you went down to do all of this, probably 7 times in the day. Now we know this is very, very impractical, and patients will always not be able to maintain this kind of thing all day, all the time. So what we can kind of possibly to come to a middle ground is tell the patient to do what I would suggest for my patients is one day to do a pre and post meal breakfast, the next day a pre and post meal lunch, and then the third day a pre and post meal dinner. And they keep repeating this cycle, maybe 2 readings a day. And then of course, if we find that there is a particular time at which the sugars are going out of range, we ask them to focus more on checking those sugars till we have adjusted our medication regimen to get all the errant sugars into a better range. Now, of course, with SMBG, we know there's a lot of inconsistency. Patients are not checking very well. They don't really maintain their diaries. I constantly have to tell the patients that if you don't bring that sugar diary to me, your entire visit is completely wasted. The more readings they get from me, the better we can guide them also as well. But of course, we know that with SMBG, hyper and hypoglycemic episodes will often go undetected, especially when readings are intermittent. However, this till date does remain the cornerstone for glucose management in pregnancy. The A1C, like we said earlier, again, we combine this with an SMBG, but of course, an SMBG and A1C is more like an average. It does give us a more, maybe an overview, kind of picture to get more complete data for glucose control alongside with the SMBG. It can help us optimize our treatment decisions. But of course, an A1C is not going to kind of guide us on a day-to-day basis with regards to adjustment of our insulin or our other doses. And as a result of which, this is not something we can rely on completely. If my A1C, let's say right now is at a 6.5% today, I can't necessarily say that the patient's control has been good all the time. Well, and of course, a limitation, like we said, it's not going to give us real-time, day-to-day data, and therefore has to be used more as guidance. Now, the new kid on the block over here that we have for glucose monitoring is CGM or continuous glucose monitoring. Now, this is a very, very useful tool. It's basically very useful, especially for patients who are unable to achieve their glucose targets with SMBG alone. It's basically also good as an educational tool. And since over here, the entire data appears to us in a graphical manner, it basically helps to also empower and engage our patients in their own care, because through this graphical representation, they can see at which times their sugars are going high and therefore are more engaged in making changes, whether dietary, whether on the insulin perspective. They're more willing to get involved with all of that when they are able to see the results of whatever they are doing themselves. Now, the caveat and the limitation over here that it does require more specialized knowledge and patient education. Just to show you what this involves, I'm sure majority of you all might have seen this already. So you have this glucose sensor. It's attached maybe like at the back of the arm. It has basically a little kind of tip that sits in the interstitial fluid and takes readings continuously. And then basically there's a chip in it, which the data is picked up by this reader. The graph that I was talking about, this is the graph that gives you a continuous graphical representation of the sugars. And like, for example, in this patient, there are these lows and these highs that are happening will not generally be picked up by self-monitoring of the plasma glucose, but can only be picked up by a CGM. And the CGM basically can then guide you, because we know that suppose this patient was on insulin, at this time of the day, the patient is going low. At this time of the day, the patient's sugars are going high. We know which insulin, what amounts of insulin we need to readjust in order to get our glucose back into good control. So in pregnancy, there is a huge amount of variability, of glucose variability. So these are graphs of 3 patients between 24 to 28 weeks of gestation There are patients with type 1 diabetes with LGA neonates, like you're seeing. These 3 women had average glucoses of roughly 100, 140, and 200. The green stripe represents over here the desired glucose range at which we want to keep them at this time in pregnancy. But like you're seeing, the excursions over here represent where their sugars are going to, especially when you're looking at the higher average glucoses. So this increased glucose variability is predictive of an asymmetric fetal growth and increased risk of macrosomia as well. So this is another meta-analysis. This was another group over here that basically showed that the higher GV in GDM is greater as compared to normal pregnancy and non-pregnant females. And in GDM, even when there are transient periods of hyperglycemia, this can lead, in fact, to accelerated fetal growth, especially in the 2nd and 3rd trimester. So the use of CGM has been good in terms of the reducing risk of macrosomia. Like you're seeing in this one trial, the odds ratio 60/35, its odds ratio has come down to 0.36 in the CGM treated group. So talking about the aspect of time in range, so these are the values that are recommended for patients with type 1 and type 2 diabetes. And for pregnancy as well, our primary targets are to try and get the patients into target range for roughly around 70% of the day. So for non-pregnant patients, this is roughly around, we want it between 70 to 180 for around 70%, which is 16 hours and 48 minutes of the day. For pregnancy, I'm showing you over here, for pregnancy in type 1 diabetes, again, we want this for 70% of the day. Our target range in pregnancy much tighter. So we want this between 63 to 140. The hyperglycemia levels, so like you're seeing in non-pregnant patients versus pregnant patients, we allow for this to happen roughly around less than 30%, 25 to 30% of time. Again, for patients who are pregnant with type 1 diabetes, hyperglycemia of more than 140 is acceptable at less than 25% of the time. Hypoglycemia, on the other hand, we want it for less than 5% of the day. The lesser, the better, of course. For patients who are not pregnant, this is less than 70 or less than 54 for less than 1% of the day. That's, more severe hypoglycemia. And for pregnancy, less than 63, which is defined as hypoglycemia as per this study, is less than, again, 5% and 1% for less than 54. So basically, conclusion is that each incremental 5% in the time in range, and this is what we're calling the time in range, is associated with a clinically significant benefit for patients with type 1 and type 2 diabetes. There is some further evidence on this front as well. This was the concept trial, which was used to examine the effectiveness of CGM on maternal glucose and obstetric neonatal health outcomes. This was basically done an RCT over 12 months in 31 different hospitals. Pregnant and planning pregnancy planning pregnancy groups were assigned CGM plus SMBG versus SMBG alone. So what the results over this showed that there was no apparent benefit for CGM for patients who were planning pregnancy. But for patients who were already pregnant, the CGM intervention group spent an increased amount of time in the recommended glucose target range and reduced time in the hyper and hypoglycemic group time range as compared to the control group. Even the number of severe hypoglycemic episodes were much lesser. And so the conclusions over here were that basically—
We have 1 minute left if you can.
Yes. So I'm finishing in 2 minutes now. So there was lesser time in hyperglycemia and hypoglycemia. A1C reduced the neonatal outcomes also, lesser admissions, lesser hypoglycemia, and lesser hospital stay. The economic question comes, does CGM win over SMBG from the point of view of cost? And if you look at this whole thing, just the number of NICU admissions, the duration of stay, much, much lesser with the CGM group as compared to the SMBG group, bringing down the overall cost humongously. So just in conclusion, every 5% time in range matters to reduce all of the negative neonatal outcomes. Finally, Sita has delivered a 3 kg child. She asks you, do I need to take insulin and monitor sugars lifelong? Well, you're going to have to counsel her now. So basically what we have to inform our patients that 5 to 10% of patients will develop type 2 diabetes immediately postpartum, 50% over the next 10 to 20 years. counsel the patients for a healthy lifestyle, metformin and breastfeeding. This is your best chance here. Reevaluation for glucose monitoring has to happen with the 75 grams OGTT at 6 weeks, 6 months, and triannually. Different societies give different recommendations, an annual FPG and an HbA1c. So thank you. My last message is that basically for all of us who have the onus on us of managing patients with diabetes, it's very important to maintain tight glycemic control. Possibly if we screen them in time, maintaining diabetes control at when it is required, we possibly can prevent India from becoming the next diabetes capital of the world. Thank you.
Thank you, Piya, for that excellent lecture. So many take-home messages. We have time only for one question. Uday, if there are any questions, there's one question, but that's related to metformin, whether it's by Sudha Sharma.
I think Dr. Shashank will be talking about metformin next in any case.
Okay, we can ask at that time. Uday, you have any questions for Piya? Otherwise, we go on to the next.
Piya can answer that question because I don't know if Shashank is there or we are showing a recorded talk.
So should metformin be given to all PCOS patients who become pregnant or only those who are obese or at higher risk of GDM?
Sorry, this is for pregnant or non-pregnant patients we're talking about?
No, so giving all PCOS patients who become pregnant,
right?
Only those who are obese or are at a higher risk of developing GDM.
All PCOS patients should be given metformin. Who are pregnant. So if they're already, like we discussed this earlier, if they're already on metformin, we probably will continue it into pregnancy as well. It all depends on whether they become diabetic in pregnancy. That becomes the bigger question, which will require monitoring as well. Generally, if it, then otherwise we're generally discontinuing it at maybe the end of the first trimester, monitor the patient, and then go on to see whether diabetes is there or not. But no, it is not the standard of care to necessarily to continue.
Thank you, Piya, for